I think everyone should give themselves a round of applause. I can't believe you're all still hanging in there. It's awesome. Great job. So I'm going to call your attention to the case study, and then there's a discharge assessment and a SOC Rock assessment that are in your folders. We're going to be working as groups to complete these on the case study. And I'm going to go through these slides very quickly. The acronyms, again, you've seen these all. You know that there's handouts in your packets. For the case study, we're going to be working in groups at your table to complete those two items that I mentioned for the SOC Rock and the discharge. We're going to be looking at all of these M items and the GG item that we talked about over the last couple of days. So you'll be reading the case study, pulling out the pertinent information, and then completing the assessment just like you and your staff would be doing. Again, we've called attention to the documents, and we'll be doing this over a 25 to 30-minute period. Again, don't worry about the term code and coding. We're talking about scoring those items. We're going to introduce you today to Mr. B. He's a 72-year-old Caucasian male. He lives with his wife. 9 months ago, he underwent a right below-the-knee amputation due to diabetic complications and peripheral vascular disease. He was independent with his new prosthesis, which he received 4 months ago. He was emergently treated at a local acute care hospital following a fall, was discharged from acute care with the following diagnosis. He had a stage 3 sacral pressure ulcer, an epidural abscess, methicillin-sensitive Staphylococcus aureus, or MSSA bacteremia, hepatic encephalopathy, alcohol withdrawal, a right BKA, hypertension, you're getting all this? Type 2 diabetes and peripheral neuropathy, PVD, a lower left extremity weakness, and a left wrist strain, to name a few. Poor Mr. B. So the home care agency received a referral for nursing, physical, and occupational therapies and home health aid services. He's returning home following a 4-week acute care hospital stay. So we're going to give you about 25 minutes to go through the case study. Again, this is an opportunity for you to, really put to work all of the great things that you've learned over the last couple of days and in the last few months using the OASIS C2. And we'll join back at 3:30 to go through each of the items. I will be walking around if there's any questions, and my colleagues will also be available to help you if you get stuck on anything. Thanks so much. Good luck. Okay, everyone, we're going to come back together and go through what a great job you all did on this case study on poor Mr. B. I got a lot of condolences on poor Mr. B. We were kind of mean to him, huh? We added a lot of things, but I'm sure you did a great job. As I mentioned, we're going to be going through each of the items that we've reviewed over the past few days. We are going to move through these relatively quickly because there is a lot to go through. Then we will be getting back together for questions and answers at the end. So the first is the active diagnosis. So how would you respond, or how did you respond to M1028, the active diagnosis? Did you check 1, 2? Oh, 100%. Everyone answered C. Did we all answer that? I think I went a little quickly on that one. So we all did great on that. Okay. And the active diagnosis, the rationale on that was that poor Mr. B had both peripheral vascular disease and PAD and diabetes. So the PVD was an active diagnosis due to the presence of neuropathy and the history of the amputation due to circulatory issues. And then this active diagnosis was confirmed by the physician. And diabetes is an active diagnosis as noted on the hospital discharge summary and confirmed by the physician. And there's ongoing medication and dietary management for that diagnosis. So It was both. So for the second, one of our favorite ones that Kathy Roby went through, M1060, the height and weight. So for 1060A, and if you want to use your clicker there, what did we enter for the answer? I hear C. C is the correct answer. Good job. And how about the weight for 1060B? And the answer for that was C, 220 pounds. And for height and weight, according to the agency policy and due to safety concerns, the patient's height was measured while lying flat in the bed using the longest lower extremity that Kathy Roby had reviewed with you earlier. And the patient's weight was also obtained according to agency policy, and that's always critical with these measures, for obtaining the weights on an amputee, which required both the weight of the prosthetic and the shoes to be deducted from his weight. And mathematical rounding was used for coding for both the height and the weight. So now we're moving on to the current number of unhealed pressure ulcers at each stage. So for M1311, the current number of unhealed pressure ulcers at each stage. For A1, and you can call out on this, please. For B1, 1, yeah. For C1, 0. For D1, unstageable, non-removable, 0. E1 is 0. F1, 0. Great. And A2, B2, C2, D2, I feel like I'm in Star Wars, you know. And F2 are omitted on the sock rock. And the rationale, the admission skin assessment completed by the nurse revealed that Mr. B had that pressure ulcer on his sacrum. Upon review of the discharge summary, the nurse identified this as a stage 3, and it developed in the hospital. Even though it appeared as a stage 2 on the start of care, the nurse understood that the wound must be staged at its worst stage until healed, and reverse staging is clinically inappropriate because pressure ulcers do not heal in a reverse sequence. So we're moving on to M1620 for bowel incontinence. And how did you respond to M1620 for Mr. B? This is jumping ahead quicker than... And the answer was B. For 2, because he had that some challenges getting to the bathroom on time, 1 to 3 times weekly. So the answer for that was B. And for bowel incontinence, the rationale, due to his recent hospitalization and medical issues, Mr. B was deconditioned and had difficulty reaching the bathroom in time, as you saw, and these incontinent episodes occurred 2 times over the last week. For GG0170C, lying to sitting on the side of the bed. So how did you all score GG0170C1 for the sock performance? Great job. So the answer was code 3. For partial moderate assistance, and that was because Mrs. B, his wife, assisted by holding and supporting his trunk, so great job. She provided less than half of the effort to complete the activity, helping him move from lying to sitting on the side of the bed. The case study talked about her supporting his trunk as he moved his legs over to the edge of the bed to assist him to the sitting position. And although Mr. B's amputated right leg does not touch the floor, he was still able to sit safely on the side of the bed. And for the discharge goal for GG0170C2, great job. So the answer to this was a code of 6 for independent. And the reason for that was the nurse did expect Mr. B's wrist strain that was impacting his ability to perform the task. She did expect that would improve so that his wife would no longer need to provide trunk support, and that he was expected to perform the activity of lying to sitting on the side of the bed independently by discharge. So moving on to that non-controversial topic, the drug regimen review. How would you respond to M2001? The answer was B, the response was 1. And the reason or rationale for that: did a complete drug regimen review identify potential clinically significant medication issues? Mr. B's list of meds from the acute care discharge instructions did not match the meds that the patient showed the clinician. The Captopril was in the home, but it was not on his discharge orders, and the patient stated that he took that Captopril twice a day. The clinician considered this a potentially clinically significant medication issue, the duplicate therapy. So the answer for M2001 was yes, 1. And then for medication follow-up, which was M2003, how did you all respond for M2003, the medication follow-up question? Great job. So we had 93% answer correctly for B, which was a response of 1. And again, did the agency, this is our favorite, contact the physician by midnight of the next calendar day and complete a prescribed recommended action in response to the identified potentially clinically significant medication issue? And the nurse, as you recall in the case study, she did telephone the physician during the start of care. During the assessment to discuss and resolve the identified medication issue. And she did initiate the orders by reviewing them with Mr. B and his wife, confirming their understanding and ordering the wound care supplies. Upon return to the office, the nurse also faxed the physician the medication list and recommendations. And the following day, the physician, of course, because all our physicians do this, signed and faxed the medication recommendation list right back to the nurse right on time. So it's a happy story with Mr. B. So moving on to the discharge assessment. So the first item is M1311, current number of unhealed pressure ulcers at each stage. For M1311, the pressure ulcers at each stage, and we'll call out the answers again on this. So for A1, stage 2, yeah. And for A2, that would be a skip, yeah. For B2, 1, yeah. And for B1 and B2 is a skip, 0, yeah. 0. For C1, 0. And C2? Yep. For D1? 0. And for D2? A skip. For E1? And for E2? Skip. And for F2? 0. And F2? Skip. Yeah, great. And the rationale for this, upon discharge, the stage 3 pressure ulcer was healed on Mr. B's sacrum, but the patient had developed a new stage 3 pressure ulcer on his right hip, and therefore M1311B1 was coded as 1. M1311B2 is coded as 0 because the number of stage 3 pressure ulcers, the current stage 3 pressure ulcer, on the right hip was not present at the start of care, but developed during the home health quality episode. So that's why it was 1 for 1311B1, but 0 for 1311B2. So the next item, M1313, the worsening in pressure ulcer status since SOCROC. So we'll call out the answers for this again as well. So for 1313, worsening in pressure ulcer for Mr. B, for A, stage 2. Great. And for stage 3, correct. For stage 4, 0. For unstageable, non-removable dressing, 0. Unstageable sloth or eschar, 0. And unstageable deep tissue injury, 0. Great. And the rationale for that was upon discharge, the patient was assessed to have a stage 3 pressure ulcer that was not present at the start of care. So moving on to M1620 for bowel incontinence. So how did you all respond to M1620? This is another polling question. A 100% got that correct. Yep, the answer was A, and the response was 0, very rarely or never. And the rationale for this was because upon discharge, Mr. B was continent of bowel and independent in toileting. So we had conditioned him, and he was doing so much better that he was able to get to the bathroom with no problems. And for M2005, medication intervention. And this is another polling question. How did you respond to M2005? So 92% got this one correct, and the response was 1, yes. And the reason for this, for M2005, medication intervention, did the agency contact and complete physician or physician designee prescribed recommended actions by midnight of the next calendar day, each time potentially clinically significant medication issues were identified since the SOCROC? And the response was 1, or yes, and the rationale being that there was a clinically significant medication issue that was identified by the nurse at the start of care. It was resolved in a timely manner using the required two-way communication before midnight of the following day. In addition, during the episode, there were 2 incidences of hyperglycemia that were noted. The nurse considered these issues to be potentially clinically significant medication issues and that did necessitate physician contact. On both occasions, the physician was notified and responded on the same day, of course, the same wonderful physician, with same day, and symptoms were noted by the home health agency with no change in orders. So the response, again, 1, was correct. So we did want to spend a few minutes on circling back on the quality measures, because we have tried throughout this training to share with you how all of this relates to the quality measures and how those are reported and summarized. So we thought it would be helpful to look at Mr. B and whether you feel that he would meet the inclusion criteria for the % of residents or patients with pressure ulcers that are new or worsened. So as you remember, we talked about what's in the numerator and what's in the denominator for these quality measures. The numerator, again, being the number of completed quality episodes for patients whose assessment at the end of care indicated one or more new or worsened stage 2 to 3 pressure ulcers compared to the start or resumption of care assessment. And then that would be over the denominator, which would be the number of quality episodes, except those that met the exclusion criteria. And the home health quality episodes are defined by pairing the assessments, as Kathy had outlined, completed at the start of care or resumption of care, paired with an assessment completed at the end of care. So for Mr. B, do you feel that his case, his scenario that we've gone through would fill or meet the criteria for that numerator? If you think yes, raise your hand. Excellent. And yes, we would agree with you. Mr. B did meet the inclusion criteria for the percent of patients with pressure ulcers. He had that stage 3, which we scored at M1313B. And he did have a complete quality episode, right? So we did have a matching start of care with a discharge assessment. So he would meet the inclusion criteria for that quality measure. We thought it would also be helpful just to look through briefly the following 4 potential risk adjustment covariates. We've spent a lot of time on that over today between Kathy Roby and myself. So when we look at Mr. B and think about the covariate 1 being GG0170C, which requires partial moderate assistance for lying to sitting on the side of the bed, and think of covariate 2, which was M1620, the bowel incontinence, covariate 3, M1028, which was the active diagnoses, the diabetes, and the peripheral vascular disease, and covariate 4, the high body mass index that he had based on his height and his weight on the SOC-ROC assessment. Do we feel that he qualified for all of these covariates, that they would be risk adjustments for his assessment? So for the first 3 that we went through, for the partial, for GG0170C, 1620, and 1028, he would meet those, but for covariate 4, he actually had a high index, and you would need a low index for that too, a low BMI. So that would not have been a risk adjustment for him for that quality measure. So he did meet the inclusion criteria for the drug regimen review, and that is defined when you look at the numerator. The agency obviously conducted the drug regimen review at the start of care, and he was taking medications, so that he qualified based on the drug regimen review. And then the nurse did identify some potentially clinically significant medication issues at the time of the quality episode. The home health agency did contact the physician, completed the recommended actions. That, as the numerator, divided by the number of quality episodes ending with a discharge or transfer. Do we feel that Mr. B met that inclusion criteria? Yeah, he did, yes. So again, just going through that again, that it was conducted, we did identify a significant issue, it was acted upon, and he did have a quality episode that was ended. It was a start of care and ended with a discharge, so that would be included in the drug regimen quality measure. So we're back at our favorite resource slide, which you all, I think, could recite in your sleep at this point, right? So we want to thank you for all of your time today. We do have a few more minutes for questions. I don't know if we want to open it up to questions now or just move into the questions that were submitted. So I'll see if, does anyone have any questions on Mr. B, on the case study? Any concerns or questions? Just want to thank everyone again for working so hard. Amazing. It's smoking in here with all the knowledge in your brains. Okay, so I think we're just going to have our team come back up with Qualidigm and CMS. And we have summarized, there have been a good number of questions that have come in, so we're going to just go through those.